Good morning, everyone, and welcome to our webinar today, Preventing Falls in Older Australians, Applying the Updated National Guidelines in Practice. It's my pleasure to welcome you on behalf of the Australian and New Zealand Falls Prevention Society, the Centre for Research Excellence in Falls Prevention of falls prevention injuries and injury matters. My name is Rachel Mead. I'm General Manager of Injury Prevention here at Injury Matters. Before we get started, I would like to begin by acknowledging the traditional custodians of the land that we meet on across Australia. For me, I'm joining you from Whadjuk Noongar country. Noongar country in Western Australia extends from north of Moora down to Margaret River and across to Esperance, and has one of the longest standing, connections of people on this land, with over 45,000 years of history for the Noongar people. And the Whadjuk country is where I am in Perth. So I'd like to acknowledge the traditional custodians here on Whadjuk country, or wherever you are joining from across this beautiful country, and pay my respect to any Aboriginal or Torres Strait Islander people who are joining us in the webinar today as well. Just quickly, a little bit of housekeeping. So all participants at the moment, you will be on mute. However, there will be an opportunity for questions throughout the Q&A panel at the end. Throughout the session, if you have any questions or thoughts that you would like to pose to our illustrious panel, please pop them in the chat function. We'll be monitoring them, and we'll have some time at the end for you to ask. If you have any problems with accessing information, please, issues with hearing, yell out, and we will see if we can help you. Joanna is in the background and will be monitoring the chat box. We will have a QR code at the end of the presentation for you to provide feedback on today's session. So please, when we get to that point, we would encourage you to provide feedback. And just finally, to let you know that we will be recording today's webinar as well. Just finally, from a housekeeping perspective, we prioritise the privacy and confidentiality of all our participants, and for the integrity of this webinar, we ask that you please do not use any AI technology to record the webinar or to share it afterwards. We will be, as I said, recording the webinar, and it will be made available, but we request that you don't utilise AI technologies to share that content. With that said, I am now going to hand over to Professor Kim Delbert, who is a Senior Principal Research Scientist at NEURA and President of the Australian New Zealand Falls Prevention Society, who's going to provide an introduction to this webinar. Thanks, Kim.
Thanks, Rachel, for a wonderful introduction to this webinar, and thank you everyone for joining as well. It's fantastic to see the numbers grow in the people attendee list. They just keep rising constantly, and it's very exciting to see that so many people are joining us to hear more about the guidelines and are interested in falls. So I'm probably preaching to the converted here, saying that falls is a big issue in Australia, but all over the world. As we have an aging population, falls does become a big health impact on the entire society, but also to the individual. Falls don't always result in an injury, but when they do result in an injury, which is quite often, they can be ultimately leading to disability. and lead to people being hospitalized, needing rehabilitation, and often also requiring admission to aged care facilities. And not to mention that many falls also result in death. With that, falls are actually the leading reason for hospitalization in older people. Like we've been often saying injury-related hospitalization, but we've been looking at numbers on that, and it is about 3 times as many times as being hospitalized for stroke, for example, that people are hospitalized because of a fall. So with this, like we really want to raise awareness to this issue to everyone. But what is really exciting about today's webinar is that we have guidelines that will help you, will help everyone to know what we can do to prevent falls for older people, because falls is one of those public health issues that we really know what we can do about it to reduce the risk of falls by about 30%. So in response to the issue, we now have the Australian Commission on Safety and Quality in Healthcare, who have just recently released the updated Preventing Falls and Harm from Falls in Older People best practice guidelines for both hospitals as well as residential care and community care. And these guidelines will offer a nationally consistent approach to preventing falls. They haven't been developed by one person, they've been developed by a team of people. And they've definitely been also developed in collaboration with experts from hospital staff, aged care staff, allied health, primary care, and health promotion. So they really will give you that total package on what we can do to prevent falls. And the webinar will feature several of these contributors. I'm very excited to hear how the journey evolved and all the different steps that were taken, rigorous steps, evidence-based, to deliver to you this high quality guideline. So with that, I will now introduce the next speaker. So we have Sue Dyer, who is Senior Research Fellow from Flinders University, who will tell us a little bit more about the evidence behind the guidelines.
Okay, thank you, Kim. I'll just share my slides here. So as Kim said, I'm going to present the evidence behind the guidelines today. And as she mentioned, a lot of people contributed to this work. And Stephen, who's speaking after me, will provide acknowledgement of a more extensive list of people that have contributed to the many steps involved in producing the guidelines. Oh, apologies. Sorry about that. Okay, so I just wanted to say, since the guidelines were last released in 2009, there had already been quite a significant update on the evidence of how to prevent falls in older people living in the community. And this was in the form of published Cochrane collaboration reviews. And these reviews are considered the gold standard of evidence synthesis. So Cochrane collaboration reviews have really extensive methodological processes, review processes both within Cochrane and external to Cochrane, and strict conflict of interest policies for the authors. So these Cochrane collaboration reviews were the main source of evidence for the evidence-based recommendations in the guidelines, and these can be freely accessed through the Cochrane Library, and there's existing Cochrane reviews on exercise, environmental interventions and multifactorial interventions. And I'll give you a really quick overview of the findings of those. Now, in updating the guidelines, the most recent Cochrane review on falls prevention in care facilities and hospitals had much more limited evidence on how to prevent falls. But a number of studies had been released since that time, providing an increase in the amount of evidence, and we were working on an update of this Cochrane review at the time. And so evidence to December 2021 from the In Progress Cochrane Review for Care Facilities and Hospitals was used to inform the Australian guidelines, and I'll give you a brief insight into that. There were also additional literature searches conducted around all the falls risk factors and reference to the World Guidelines for Falls Prevention that were released in 2022 that a number of us were also involved in. But I'll be presenting to you the evidence for the first two of these. So that's the randomised controlled trial evidence as identified through the Cochrane collaboration reviews. But before I do that, I do need to have a little bit of a technical background. And so when we talk about falls, within trials, we can, and in hospitals and care facilities in the public, we can measure and report falls in a couple of different ways. So we can talk about the rate of falls. So that's actually the total number of falls per unit time. And so this is often how falls are reported, say, in hospital data, and they'll talk about the falls per 1,000 occupied bed days, for example. We can also talk about the number of people falling, so the chance of someone falling or the proportion of the total people that we're monitoring, how many of them fall, whether they fall one or more times. And so there's those two different outcomes. Now, when we're looking at randomised controlled trial evidence, we're looking at a group of people that are receiving an intervention that we're examining whether it can reduce falls, and a group of people that are randomised to a control, so they don't receive the intervention at all. And in terms of outcomes, we'll look at the ratio of the number of falls in those two groups. So you can see that if they have the same number of falls in both groups, the ratio, whether it's the rate ratio or the risk ratio, will be 1. But if the intervention we're looking at reduces the number of falls, then the ratio will be less than 1. So that's indicating a reduction in the falls. As we go through the evidence, you might see that for some interventions, or quite often, the rate of falls is reduced to a higher extent than the number of people falling. And that's not that surprising. So it might be for some interventions we can prevent some falls, but some people are falling a lot of times. So it's much harder to make sure they don't fall at all. But this is still really important if we only reduce the rate of falls, because every fall, as Kim said, can result in injury, hip fracture, admission to aged care, and even death. So both outcomes are very important. So first, if we look at the evidence behind the guidelines for preventing falls for people living in the community, one of the main Cochrane reviews that presented evidence on how to prevent falls was one by Kathy Sherrington on exercise to prevent falls. And this review looked at 108 randomised controlled trials and showed that the rate of falls can actually be reduced by 23% and the number of people falling by 15%. There's also a Cochrane review examining environmental interventions to prevent falls, and so that's looking at home modification as well as personal aids. This looked at 22 randomised controlled trials and showed that home fall hazard reduction can reduce the rate of falls by 26% and the number of people falling by 11%. But importantly, when you specifically look at the group of people at a higher risk of falling, so for example, people that have just been discharged from hospital or that have already had a fall in the previous 12 months, these interventions can reduce falls by an even greater degree. So they can reduce the rate of falls by 38% in the high risk population living in the community. There's another separate review looking at multifactorial and multi-component interventions to prevent falls. Now, multifactorial interventions are those where all of the people receive a combination of different interventions to prevent falls, and that's based on a falls risk assessment. So they get a tailored intervention based on their individual risk factors for falls. And that might include, different combinations of interventions for different people. When we talk about multiple component interventions, people are also getting a combination of different interventions, but they're all getting the same combination. So, for example, everyone might get an exercise program and perhaps an environmental modification or a medication review. And what this review found after looking at 62 randomised controlled trials was that multifactorial interventions can reduce the rate of falls by 23%. So they're those tailored, individualised interventions where people are getting multiple different things. And multiple component interventions can reduce the rate of falls by 26% and the number of people falling by 18%. Now, when we come to falls prevention for older people living in care facilities or nursing homes, as I said, we were using evidence from an ongoing update of the Cochrane Review to December 2021. We've continued working on this, and since that time we've got a number of publications with updated evidence to prevent falls in the population, and you can access all of these articles are freely available, and you can look at the updated evidence. The Cochrane Review update is also being published separately for care facilities and for hospital settings. And we actually had the Falls Prevention in Care Facilities review accepted for publication just this week. So that should be publicly available in a month or two. And hopefully Falls Prevention in Hospitals, the Cochrane Review, will be available later this year. The conclusions from all of this work is very similar to what we had at December 2022, even though that didn't use the extensive process in the Cochrane Reviews, like contacting authors to get additional information and dredging through the trial registry records to find additional studies. The conclusions are very similar. So the data that informs the evidence-based recommendations for older people living in care facilities shows that vitamin D supplementation can reduce the rate of falls by 37%. And also using a dietitian in the care facilities to ensure people are getting at least 3.5 servings of dairy foods a day, in addition to their vitamin D supplementation, can reduce the number of people falling by 11% and the number of people with a fracture by 33%. We also found that in care facilities, those multifactorial interventions, so where everyone gets an individualised combination of falls prevention interventions, which in care facilities also needs to involve education of staff on how to deliver these interventions, can reduce the rate of falls by 36% and the number of people falling by 22%. We've also got new evidence that exercise can also reduce falls in this population living in nursing homes. But what's important is that exercise needs to be ongoing. It needs to be a continued part of their care, and that can reduce falls by 31% and the number of people falling by 17%. But what we did find was if that exercise program is stopped, the benefit of that over time is lost. So if we compare a group of people that received an exercise program to those who didn't, after a period of time, their falls rate is exactly the same. It's really close to, the ratio is really close to 1. So as I said, that exercise program needs to be an ongoing thing to see that benefit of falls reduction. When it comes to hospitals, there were 2 Australian trials, which were non-inferiority trials, that showed that where you compared a risk assessment with a scored component of the risk assessment tool compared to risk assessment and giving the interventions only, there's no benefit from having that scoring component of the risk assessment. And in fact, the falls rate combining those 2 trials was slightly higher. There's evidence that education interventions that are provided to staff and patients in hospitals can reduce the rate of falls by 26% and the number of people falling by 38%. The multifactorial interventions, which are individualised based on that risk assessment, can reduce the rate of falls by 14% and the number of people falling by 18% in hospitals. But this evidence isn't quite as strong in this setting, and you'll see that reflected in the strength of the recommendations that Stephen will talk about after. And also finally, after a hip fracture, when people are in hospital receiving care after their operation for their hip fracture, there is a really significant reduction in falls. It's only shown in one study, but it's a large reduction where people receive care in a specialised geriatric orthopaedic service providing care for older people in comparison to receiving care in a standard orthopaedic ward. And this can reduce the rate of falls by 62% and the number of people falling by 59%. So that gives you an overview of the evidence that we have collated that informs the evidence-based recommendations. And now I'll hand back to Kin, who will introduce Stephen, who's going to talk about the extensive process in producing the guidelines beyond just the review of the evidence. Thank you.
Such a wonderful summary of the evidence behind this, and you are really a superstar at collating all those numbers together and helping everyone to make sense of them. So thank you so much for presenting this. So yes, our next speaker, thanks to, is Professor Stephen Lord. So Steve is CNCR professor at UNSW, but he's also a senior principal research scientist at NEURA, and he's also the best cited and most published researcher globally in falls prevention. So we're very lucky to have Steve presenting today about how the development of the guidelines came about. Steve, I will hand it to you.
We're just dealing with some technical issues, Kim.
Okay, thank you. That's
Like,
Jackie
like,
that
like
we
he's
can
in,
hear.
like he's in my office. Right, let me see if I can find the. What can you see on the screen now, Kim?
So we can see the slide, but not in the slide presenter's view, but in
That's
the...
fine. That's easy to address.
Yes.
I'll vacate my seat.
Well, thank you, Kim, and thank you, Jackie. It was very good to have Jackie in the next office. For some reason, my access to my mic and camera were denied, so it made it a bit difficult to present the talk. But here I am, and so what I'm going to talk about is just to give a brief history of where the guidelines came from, and then from there, actually another brief overview of exactly what is in the guidelines and the recommendations and good practice points that they contain. So going back, the first iteration of any guidelines within Australia was an initiative of Queensland Health, and this was from 2003. And this was best practice guidelines, a single volume for public hospitals and state government residential aged care facilities. So this came out in 2003 and it was quite a breakthrough, and it was only then within 2 years that what was then the Safety and Quality Council developed further from this, used those as a baseline, but then brought into account a quick reference guide for preventing falls for older people, as well as guidelines that looked at both hospitals and residential aged care. And if anyone has got a long memory, this was known as the green box because this particular version came with a number of different additional components that helped with implementation of the guidelines. Following on from this, what then became the Australian Commission into Safety and Quality in Healthcare, then revised these particular guidelines and in fact converted them to 3 separate ones, one for the community, one for hospitals and one for residential aged care, with the aim being that by doing this, people in these particular settings would have recommendations that were totally specific to their work and their care of older people. So this was in 2009, and so from there has been a bit of a break. In fact, 16 years before we've got the 2025 updated guidelines. They have much the same form as the 2009 ones. There's one for hospitals, one for residential aged care, and one for community care. and they've used the same sort of structure at the beginning, looking at general approach to fall risk reduction, and then addressing individual risk factors one by one to lessen the risk of falling. So the authors and acknowledgements, there are a lot of people. These are some of definitely the main people who've contributed towards this work. It has been a work that's been undertaken over many years. But this particular iteration, probably 5 years or so, this has been in a sort of being drafting and redrafting and revised in terms of external comment and so on. Particularly like to acknowledge Associate Professor Jasmine Manat, who really is the first author for all of this work and really did work to make sure that all of this work was synchronized, make sure everything was consistent across volumes and so on, and did much of the work, as well as the other authors you can see there. The assistance we had there with literature searches, quality assessments and data extraction, and also critical review. So what's in the guidelines? There are 3 versions of them. The guidelines themselves are about 30 pages each, and they primarily involve a bit of a background, then the recommendations and the good practice points. So it's really the skinned down version of all of the evidence. There are fact sheets. I have one over there on the right. They're usually 2 pages or so, and they're very brief, and they're for people involved in organisation of fall prevention in healthcare services. There's a 3rd version, and that's the reference documents, and these are about 200 plus pages each. So this is really all of the evidence, all of the literature reviews that the evidence was based on. They also contain some resources and useful links, case studies, special considerations, assessment tools, and so on. They're also available. You can't download them directly, but they're available from the Commission website by submitting a form, and they will be available. And there's a lot of information in there to help with implementation of the actual recommendations and good practice points. In addition to writing the guidelines, there was really extensive formal external consultation of the recommendations and the best practice points. 2 extensive rounds, in fact, over the last 2 years to really make sure these guidelines were sent out to all interested parties so that we could get feedback on all of the individual recommendations and good practice points. Also, the Commission itself reviewed it in terms of make sure it was consistent in format, terminology, and consistent with other Commission guidelines and policies. So this is the process that it's been through to finally being launched just last month. Sue mentioned levels of evidence, and I'll just touch on this briefly, but this is how all of the recommendations are graded in terms of the strength of the recommendation, either strong or weak or conditional, and also in terms of quality, which is high, intermediate, or low. So everything that is in the guidelines that has a recommendation, though, is based on at least a randomised controlled evidence and with a clear impact on fall risk. So strong, 1A being the strongest, 2C being the lowest, but even at a level of 2C, it does mean that randomised controlled trials have been conducted, have been shown that that particular intervention can prevent falls and in that setting. So recommendations are pretty good to follow. So I'll just go through these briefly. Sue has given the evidence, but in terms of the wording, you can see them here. These slides will be available, and of course they're available in the guidelines themselves. So in hospitals, there are 4 recommendations with evidence ranging from 1B, 1A right down to 2B. The first one is providing tailored education to older people who choose to participate, to all staff and families. The second one is about multifactorial fall prevention, and that this should be personalised interventions for all. And also the issue there of not needing to calculate a falls risk score, as it is not necessary. The third one is about after hip fracture, and this is to provide post-operative care in a geriatric orthopaedic service. And this has got good level of evidence at level 1B. And the final one is at the intersection between the hospital and home, and that is on discharge planning to arrange a home safety intervention delivered by an occupational therapist. So there are 4 key recommendations for the hospital. For aged care, there are more. On this page, we've got providing multifactorial prevention strategies, and there are a number of components there that have been included in the very successful multifactorial interventions, because as you can imagine, they've not all been the same, but these are the key elements for effective intervention. The second one relates to exercise. It should be tailored and supervised and ensure that a health professional is involved. And the final one is this issue about needing to maintain the exercise, because if people stop exercising, they lose the benefit. That's very strong evidence that the relative risk returns to 1 if people actually stop exercising. More interventions and recommendations for aged care. This is a relatively new one in terms of bringing in an intervention that's related to diet. And this intervention not only reduced falls, it also reduced fractures. So that was providing at least 3.5 serves of dairy foods each day. This next one relates to vitamin D supplements, and this is clearly still the case with level 1 evidence that provided the doses provided daily or weekly, and avoiding monthly or yearly megadoses, which may actually be harmful and cause falls. The remaining one relate more to fall injury, so that is providing prescribed osteoporosis medicines for older people with osteoporosis or a history of low trauma fractures, and also to consider the use of hip protectors to reduce the risk of fall-related hip fractures. In the community, there are many more interventions, so I'm going to skim these a little bit more shallowly. The first key one is really about exercise, and this really is quite clear that ongoing exercises for all people is recommended, that it should be for 2 to 3 hours a week. It can be community or safe home exercises for lower risk, but more tailored for those at increased risk, and with extra support for people with cognitive impairment. And the bottom one there, it relates to ensuring that home safety from occupational therapy is provided if people are at increased risk. For instance, as I mentioned before, if they've recently been in hospital, but also, for example, if they've got a significant visual impairment. Also within the community, there are lots of single interventions that work for people with particular risks. Cataract surgery for those with cataracts, podiatry interventions for those with foot problems or disabling foot pain, medication reviews, pacemakers for those who've got a particular issue relating to cardioinhibitory carotid sinus hypersensitivity, eyewear prescription at single lenses when people are outside rather than multifocal glasses, and making sure when a change of prescription of eyewear is made, it's not too large. Vitamin D supplements weekly or daily if people are vitamin D deficient or have little sunlight exposure, and osteoporosis medicines as well if people have osteoporosis or low trauma fractures. Then finally, there are the multi-component and multifactorial interventions, and one of these includes stepping on, which is a home community safety, education and exercise if at high risk, and also tailored interventions after individualised assessment from a health professional, particularly if increased risk of falls. So these are all ways in which falls can be prevented by multifactorial approaches, but also by addressing individual risk factors in those people who have them. So in summary, this is for the community ones, but it's generally the same for all 3. What's changed in the time between 2009 and now, there's more emphasis on actually putting the interventions in place. Assessment is still crucial to inform them, but the emphasis is actually making sure interventions are put in place, and highlighting also different approaches to intervention for people with different levels of risk. Much has stayed the same because it's at a growing body of evidence. The intervention categories recommended have stayed the same, and the inclusion of best practice points that guide all aspects of care for older adults in the community and the other settings relative to falls and falls injury are still there. These are also definitely worth looking at. These cover all different aspects that are related to falls. For example, examples include visual impairment, feet and footwear, dizziness, syncope, hearing loss, cognitive impairment, etc. And each chapter in the reference guide, as well as in the guidelines, give more detailed information as what you might be able to do to address that particular risk factor, and in doing so, reduce the risk of falls. Many of these are not being made as recommendations. They're based on expert evidence, or there's evidence that you can actually intervene to address this risk factor, but it's not been shown conclusively that that leads on to a reduction in falls. So many of them clearly have advantages and benefits for older people, but there's missing one level of evidence in terms of actually showing in a large randomized control trial that they prevent falls as well. But very good for the management of older people in terms of providing good care and assisting in fall prevention. So I'll leave it there. Thank you very much.
Thank you, Steve. I'm glad we could sort out the tech issues by moving next door.
Well done.
Yeah, thank you. So the next part of this webinar will be a panel discussion that will be led by Professor Kathy Sherrington. And Kathy is a director of the CRE in the prevention of falls injuries. And she's also a professor at the University of Sydney with the School of Public Health. And she's done an amazing amount of work in relation to lots of clinical trials. I think it's about 50 by now, and even more well known for the several Cochrane reviews, especially the ones on exercise that are one of the best cited papers, not just in falls, but in other areas of geriatric health as well. So really pleased to introduce Kathy. And so what this panel will be about really is about what the changes are and what this means for clinical practice. So Kathy, I will hand over to you. Thank you.
Excellent. Thank you very much, Kim. And yeah, fantastic to be here and fabulous to have so many people joining us online. So I guess for this next bit, we wanted to try and talk a little bit about some clinical implications. And so we've assembled a group of experts, so researchers and clinicians. And so I'm just going to ask a couple of questions each, really about the implications for the guidelines for activity now in your setting, and about how we could be sort of doing things differently. So first of all, I'm going to throw to Professor Jackie Close, who's a senior staff specialist geriatrician, as well as a leading researcher in falls prevention and hip fracture care. So Jackie, in terms of a sort of hospital outpatient context, what do you think people, can be doing now with their current resources in terms of implementing these guidelines?
Thanks, Kathy. I mean, the irony is you're starting with hospital outpatients, and that's a sort of multifactorial high risk population, which is the small end. And of course, we're funded in terms of providing comprehensive geriatric assessment. There are Medicare item numbers. So if you've got a hospital with a falls service, that part of it is funded. The bits that aren't funded, which is frustrating, is the physio in terms of delivery of exercise, and the OT component of it. And I personally am seeing less and less OT home visits being done over time, which is completely against what the evidence base says. But I guess from looking at these guidelines, I see that if people read these, we will have a very well equipped workforce able potentially to deliver interventions. The gap that I still see is the public health message. People still don't particularly want to come to a falls clinic. They're not doing the exercises they need to be doing. So I think that's a big gap in terms of trying to prevent falls at a national level. I know you and Kim have been doing a lot of work to try and change that. And we really do have to get that public health message out there, less so in terms of going to a falls clinic, but very much more so in terms of getting people to exercise, do the right exercises, and continue doing the right exercises for life. So yeah, I'm at one end of the spectrum in terms of seeing complex people who the Medicare system already funds us. I think the gap's at the other end of the spectrum.
Perfect. Thank you, Jackie. Do you think there does need to be more falls clinics, though? Do you think that everybody coming to a hospital, has sufficient access to a falls clinic and, the type of specialised assessment that, you and your colleagues are able to provide?
Do you know the jury is out in geriatric medicine? Some people prefer to label it as a falls clinic, like our clinic is a falls and bone health clinic. It is what it says on the label. But there are other geriatricians who say, actually, but we do that as part of comprehensive geriatric assessment. And maybe for some people, that's a more attractive option rather than calling it a falls clinic. I don't think it matters a lot in terms of how you label it, as long as you're doing the right things, handing out the right information and having access to the right interventions.
Now that makes perfect sense. And so I guess you're saying, things need to be kind of locally adapted and sort of fit in with the kind of current service models. It sounds like you're saying there is a bit of a need for, more allied health services for you to refer to, though. So within your clinic, if you're sort of identifying issues, then hard for you to really get those interventions happening. Is that what you're saying?
Oh, I think allied health in hospitals is becoming increasingly stretched. And equally access to allied health in the community is challenging. The resources to fund allied health in the community are certainly limited. In terms of Medicare, we've got the 5 sessions for allied health that a GP can refer to. So I can't refer to that. The GP has to refer to that. 5 is almost certainly not enough for what we're trying to deliver. But at the same time, if we've got a decent public health message out there, we also need a population that takes accountability for their own health and doesn't depend on physios or exercise physiologists delivering exercise for life. But they absolutely have a crucial role, and I don't think they're adequately funded.
Excellent. Thank you very much. That's really important insights. We might throw to Professor Anne Tiedemann next, who has a background as an exercise physiologist and has really done a lot of research in community falls prevention with a focus on exercise. I mean, Anne, would you like to comment on that sort of earlier prevention aspect that Jackie mentioned, and how we can get that happening better?
Yeah, thanks, Jackie. I fully agree with what you just said. I think one of the gaps is that we often wait for people to have a fall before we start thinking about fall prevention. So we need to be starting early with the message that keeping your functional capacity at a high level when you're in your older years is really important by being physically active, for example, so that we're, preventing the first fall from occurring. And that needs to be education across the community, not just to older people, but to their families, to middle-aged people, even younger adults, to share that message that it's possible to stay well and avoid falls. And I think we need to be sharing these guidelines and recommendations as broadly as we can in all aspects of what we do in our work, because we want health professionals to be whoever they are, whenever they see an older person, we want them to be raising this topic and talking about falls at a much earlier stage and getting across the information they're preventable. So yeah, I think public awareness, targeting all aspects of community is really important. And then finally, we need people that are delivering the exercise programs to have enough skills and to have the evidence of how to be most effective in delivering that exercise. So we need freely available education programs, I believe, training programs, so that all community exercise that's delivered to older people can be as effective as possible, not just targeting fall prevention, but all aspects of healthy ageing. And so, yeah, it's a big job, but there's lots of approaches that need to be taken.
Fantastic. Thank you so much, Anne. We might throw to Dr. Rick Dawson now. And so Rick has worked for a long time as a physiotherapist in residential aged care settings, as well as having done research in that setting, and is also actually currently president of the Australian Physiotherapy Association. I mean, Rick, would you like to comment on the implications of these guidelines for residential care, both now and for, you know, what you think is needed to help implement them?
I think what these guidelines do is highlight the importance of personalised assessment for every person living in residential aged care and making sure they get a program that's tailored for them. We know that over 50% of people living in residential aged care fall each year, and we've also got a significant proportion of them who fall regularly. So we spent a lot of time over the last 30 years doing screening. So these guidelines recommend moving towards the assessment process, and that's a big shift for the industry. But what I've seen now over the last 20 years is an increasing awareness of what everybody who works in residential aged care, and these guidelines talk about what everybody can do from a safety point of view. If you're a personal support worker, what the kitchen staff can do, what the physios can do, and what the OTs can do. Another great benefit of these guidelines is we've got the evidence to say that exercise is really important. It reduces the risk of falling, reduces the amount of people falling, but it means they need ongoing exercise. And unfortunately, 3 years ago, the government, in their wisdom, decided to take away any funding for allied health. So we've seen a reduction in physios and OTs and exercise physiologists, species dietitians by 75%. So how can allied health be supported to be in the building to give the personal tailored care that these people need when there's no funding for them? So it was a real lack of governance by the government. But there've also been some positives around. We now have every facility that tracks the amount of fallers for the mandatory quality indicators, and that's been a great transparency improvement. So we now can look at different facilities and see how they're going from a falls prevention point of view. But I think the government needs to really look at how to fund allied health in residential aged care, because for those who are at risk of falling, which is, you know, they've only had one fall this year, they need that tailored professional input. And so, yeah, I think the industry is going to really benefit from having these guidelines at their fingertips.
Excellent. Thank you very much, Rick. I'll now pass to Professor Anne-Marie Hill, who's done extensive work in falls prevention in hospital settings, including leading one of the most successful trials worldwide of falls prevention in rehabilitation settings. Anne-Marie, would you like to comment on the implications of the guidelines?
Thanks, Kathy. And it is really exciting to see the new guidelines out. And I know that speaking to a really interested, converted audience, but I think what's really important that we will all be aware of is making sure in hospital that people are receiving tailored information and tailored assessment. I think that's a really important thing. We can't suggest that if we make a list of suitable interventions, such as, you know, keeping the bed at a good height and things like that. Although they're useful, we need to be sure that we're individually assessing people thoroughly and that we're then tailoring our approach to them. And of course, a really crucial part, which is good to see recognised in the guidelines, is that we need to inform and tell and discuss with that patient. Each patient we see, we have to discuss with them what sort of plan we've got and why we've got it, because otherwise they are not aware of what the plan is, and without knowing it can sabotage the plan. So if an older person doesn't understand that they should wait for some assistance before they get out of bed, or they should talk to the nurse about toileting problems, then they won't do it. So I think that's really important. And I particularly think it's good to have that attitude, which the guidelines now mention, of consider everybody who is older, who's in hospital, or those with cognitive impairment to be at risk of falls. Don't think, well, on this ward they're at higher risk or on that ward, but just have an attitude across the hospital of embedding a safety culture. What I feel is a gap, though, is that our education trials and interventions that we keep looking at and trying to improve on rely greatly on making sure the person gets the mobility that they need, the mobility that helps them improve, that helps them go home. So they're not sitting in bed, they're actually mobilizing to the best of their ability. And that's where it's really helpful to have that discussion with the patient, really be improving them. And I think as long as we focus very heavily on getting people to leave hospital as quickly as possible, we need to consider, are we allocating enough funding for helping older people when they're in hospital to improve? So I think that's a big gap, because we don't have, I don't think, enough intensive allied health support to make sure that people are able to move around safely and improve their mobility and improve their general well-being so they can go home on a slightly rising trajectory rather than them stay in bed, decline. So, I think that leaves us some work to do there.
Fantastic. I'm conscious of the time. I'm really grateful for the insights from all four of you, and I'll hand back to Kim and Rachel for some questions. Thank you.
Yeah, thank you. Thank you very much for the panel. Super interesting to hear all the thoughts, and also been trying to read on the chat as well what people have been saying. And there's definitely a lot of questions, but also a lot of comments in relation to how to integrate as well between hospital and community and the cost effectiveness aspects and so on. But I've just also gone through a few of the questions, and I can see there's a few more recent ones now as well. But I think one of the burning questions might be, Rick. So it's in relation to exercise being a well-supported strategy across the community, but also residential aged care. And what are your thoughts around realistically addressing this shortage in the workforce, especially within aged care, of physiotherapists and exercise physiologists? And I know the APA is trying to do a little bit in that as well. Would you like to comment?
Look, I think there's a good research out there talking about group exercise in residential aged care that could be taught by trained instructors. It's in the guidelines. But I think it's important to also make sure that these people get assessed by appropriate professionals to make sure that the group programs are tailored to their needs within a group, and that so that it can be progressed. It's delivered at intensity, at least moderate intensity, so we're challenging their balance and strength, and we're getting them up on their feet. The tendency in a lot of these group programs is that they stay in the chair, and that's not going to improve their balance and reduce their falls risk. And the other thing we need to highlight in the guidelines is the value of telehealth. Now, my PhD, Kim's research is on telehealth resources, and it's the importance that there are great resources emerging that are going to support these individual and group exercise programs, and that facilities can get on board and access these resources to support their teams and staff. But also, if you can't get a physio in your local environment, there is an opportunity to, have outreach services via telehealth, and we're now able to show that these are as effective as face-to-face. It just requires some local support, infrastructure, making sure that we still can connect people using, different devices. So I think there is a workforce issue, but they still need to be in the building somehow.
Thanks, Rick. And maybe I'll just ask one more question in the interest of time, because we only have 5 more minutes. But it's a question that I saw throughout the chat a little bit, and I mentioned it a little bit beforehand as well. But and maybe Jackie and Anne-Marie, this might be a question that you might want to tap into. But how can we strengthen the links between hospital-based falls clinics and community-based programs? Do we have any thoughts on how we can improve on that?
That's such a good question.
Mm.
But the reality is we work within the confines of our funding models, and our funding models do not support, on the whole, do not support that sort of cross-discipline boundaries, particularly from a hospital funded by a state health department to Commonwealth government funded community services. It has to be about relationship building, because I don't think the funding models are ever going to change substantially to make it easier to work across those boundaries. So I think it's about working with your local health districts, people who've got roles in terms of integration, and building solid relationships between community health and hospitals. It's easier said than done, unfortunately.
Yes, I agree, Jackie. That's really the hub of the problem. I think the primary health network, it would be good if we could ensure that all GPs receive a really timely discharge letter, and that it would be good if it included something about the falls prevention referral and where the person, has, and the GP can get them access straight away. But I notice there's a shortage of programs. So once people finish a short hospital discharge program, they may not be able to get into something else. So ultimately, I do think there are gaps in relevant free or low-cost community programs that we need to work on advocating for, which comes back to that public health perspective.
And if I can
Thanks,
just
Enrique. Yeah,
just jump in. I think it's great. Geriatricians and hospitals can send a discharge letter to the GP, and if in Medicare and in primary care there were some item numbers for fall prevention, GP has a really good connection to allied health in their local areas. They can refer them to group programs or tailored individual, but we need some Medicare item numbers to support that so that there's equal access and opportunity. That's something the government could do tomorrow to get that up and running, and it would make a massive difference to connecting community to hospital and preventing falls.
thank you. And I'll leave the questions to this because I do have something else that's quite exciting that I would like to tell you all about that is coming up very soon. And that is that Kathy and myself, with Anne and several others, have had the idea to set up an alliance on falls prevention. And the main goal of the alliance really is to bring us together and come with one voice to politicians, to policymakers, and really clearly tell them what needs to happen. We have set up a website for which I will share the link through a QR code that you can then have a look at a bit further down. But this is generally what the website looks like. And so you can see on the home page, but then thanks, Rachel, you can move to the next slide. We also tell a little bit about falls, what it actually means, also from a consumer point of view. Like, this is one of my favorite quotes by Diana Olsberg. She said that a fall sentences you to social isolation, and it is so true for many people. And in the next slide, we also tell us, oh, that was interesting. Tell us a little bit about us as well and why we have decided to do this. So we really are advocating for policy change. And we also, on the next slide, will ask for some recommendations, or we have some recommendations rather, and asking for a call to action around fall prevention to politicians. And so we are really looking for you to also be part of this alliance, because we want to be a combined group of people, of community organisation, professional associations, but also individuals as well. And what we're asking for is an action plan to really guide on what needs to happen now. Like, we have the evidence, we've got the guidelines, but we've heard a lot about, well, okay, there are issues around awareness and around not having the right services available. So we will also ask for equitable provision and coordination of services to prevent and manage falls in older Australians. And Jackie already briefly mentioned it before. We will also run, or hope to run, a national awareness campaign around fall prevention. And on the next slide, you can see that we've been very busy trying to get some famous faces to join our campaign. And some of you, I think you might recognize most of them. So we have Michael Caton, who has been a driving force around like this campaign, and I just also really want to mention that we have received a lot of help from Rotary in northern New South Wales, around Lismore area as well, through David and Bob Barnes, who are our consumers on this call. And you can see Bob Carr and Craig Foster, Billy McPherson, who's an actor, an Aboriginal actor that you might recognise, Elizabeth Effort and Diana Osberg, and they have all contributed their time to help us distribute the message. And I'm very excited to share this very soon, hopefully, of what we have been able to put together. And if you're, after hearing my little spiel, are interested in joining the Alliance, please do this through the website. You can join our Alliance and register. On the next slide, you can see what you will be asked to do to register your interest. So please scan the QR code, and then you will be able to look at our terms of reference and join the Alliance as an individual, or if you are have a leading position at an organisation, please absolutely also list that organisation, and then we can put your logo on the website as well. Thank you. So that's it around the Alliance. And I just, maybe because I am the president of the Australian New Zealand Fall Prevention Society, would also like to do a plug for our conference later this year in Sydney. So it will be absolutely fantastic, as it always is. And if you're interested to hear
Oh, I think we might have lost Kim at the end there. Yeah. I will jump in quickly.
about
oh, she's back.
the yes, yeah, no.
Sorry, Kim, we were losing your connection there. But yes, strongly encourage everyone to attend the Falls Conference. It's always a great educational experience, but it's also lots of fun in terms of the events out of session as well. With that said and done, I'd like to thank everyone for their participation in the webinar. I realised we didn't get a chance to answer everyone's questions in the Q&A, and I'm kind of putting the panel on the spot a little bit here. What I was thinking is maybe I could summarise what some of those questions are, and out of session we could try and respond as best as possible. There was some around evidence and some tools and resources. So post-event, I can't guarantee how quickly we'll get back to you on those questions, but we'll share some information in relation to those questions along with the webinar recording. If everyone could please take a moment of your time to please complete our short feedback survey on this webinar. It's really helpful in guiding us in terms of what you got from the webinar, but future activities that we can support in terms of falls prevention. And I would just like to say thank you on behalf of the Falls Society, the CRE for Preventing Falls Injuries and Injury Matters, to our expert panel in Anne-Marie, Jackie and Rick. Thank you, Kathy, Kim and Stephen, for your time in pulling this event together. It was really great. I know a lot of hard work has gone into establishing the guidelines. It's our role now to really make sure that they are implemented. We all have an important role to play in preventing falls, and it's about that system, which I think we've talked about today, from community setting through to hospital and residential care, all understanding what our role is and how we can contribute to healthy ageing and maintaining independence in older adults. So thank you everyone for your time, and we will wrap up there.